Good evening. Welcome on a Friday night to the Minnesota Center for Financial and Actuarial Mathematics, our weekly seminar this fall. And my name is Gary Hatfield, and I am a professor here at MCFAM. And it is my pleasure to introduce to you Shae Armstrong. Shae is a senior healthcare economics consultant at OptumCare. And she focuses on data strategy efforts to support a myriad of users, from actuaries to data scientists, to in turn use data results to providers make the best decisions for their patients. OptumCare is one of the largest healthcare systems in the nation. If you haven't heard of it, you probably should have. And they're pretty massive, I guess. Would United Health Group, right? Is right. um, and so. In the kinds of data strategy efforts she supports ranges from data validation, standardization, curation of defining data quality standards, to operationalizing and optimizing data engines, streaming and processes. Prior to working at OptumCare, Shae was an actuarial analyst at Mercer Consulting. And Shae is friends to us because she's an alumni of the University of Minnesota Twin Cities. Majoring in both actuarial mathematics with an actuarial science emphasis, and as well as a Bachelor of Science in Economics, and also a minor in Risk Management Insurance from the Carlson School of Management. Shae was also an active member of the Actuary Club, and is currently serving as a guest lecturer for one of our actuarial science classes, Math 4067. So with that, we're very happy and we welcome Shae, and I'm just going to turn it over to Shae.
Awesome. Thanks, Gary. Thanks for having me, everyone. It's really an honor to be here and love kind of talking various U events. So let's jump right in. We got a lot to cover today. So here's an introduction on myself. Gary did an excellent job going over the various, places I've worked. Started out as Mercer, now at OptumCare Actuarial Data Strategy. A quick overview of our agenda tonight. We'll kick things off with what are the social determinants of health? What are the data sources and limitations that exist? What research has been done? And what is the future of healthcare data analytics and the healthcare industry? What are the social determinants of health? The World Health Organization has defined them as the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. These typically follow in 5 different categories. The first being economic stability, second being physical environment, third being education, fourth being food, and the fifth being social context. These are the 5 pillars of the social determinants of health. And really think about these things in the context of COVID-19, and keep in mind how one variable in one column might influence a variable in another column. Let's jump right in and take a look at some of the economic stability variables. Number 1 being employment. As of September, 12.6 million people were unemployed. Before COVID, it was about 5 million people. And as of April 2020, it was high as 24 million. And your employment has a direct correlation to how much money you make. The income to expense ratio and is an important metric for an individual and their health and financial stability. Expenses include debt, student debt, medical bills. It's also important to keep in mind the financial support and economic stability your family brings to the table. How well off is your family, and how much support do they need potentially from you? If we take a look at the physical environment pillar, the big one is housing. Where do you live? And that seems more important than ever in the age of COVID-19. As of July 2020, 1/3 of American households reported failing to make a housing payment. That was about 30 million American households. So where you live, if that's a house, an apartment, or if you do not have a house, if you're homeless, that has a huge impact on really your economic stability and your physical environment. There are other variables like transportation. How easy is it for you to get around your physical environment? Is it easy to get to work? Is it easy to get to your doctor's office? Some other aspects to physical environment are safety. How safe is your neighborhood? How many parks and playgrounds do you have nearby to get physical activity? Another variable kind of related to transportation is walkability. Is it easy to walk around your physical environment, or do you live in the middle of nowhere where it's kind of hard to get around? I think the biggest aspect of physical environment would be zip code, and a lot of models and data analysis use zip code to kind of identify a number of variables like, are you live in a rural zip code? Do you live in an urban zip code, a suburban zip code? What is the median income of your zip code? So that variable is used quite a bit in a number of SDOH models. The third is education. Some of those variables include literacy. How literate you are could definitely impact your employment status. The language you speak, is your native language the same as, say, your healthcare provider? Does the doctor speak the same language as you? That could definitely impact your health status. As well, we have early childhood education. Many studies have shown that early childhood education is a trajectory of how you're going to do for the rest of your life, which kind of brings you to vocational training and higher education. Interesting statistic, workers with higher levels of educational attainment were more likely to have teleworked because of the pandemic. Of those age 25 and over, 4% of those with less than a high school degree were able to telecommute, whereas 57% of those with a bachelor's degree were able to telecommute. So in the age of COVID-19, do you have higher levels of education and thus maybe having a job that maybe gives you a little bit more security? The fourth is access to food. So hunger levels since the pandemic have kind of skyrocketed, mostly probably because there's been a huge recession. Employment status for many people is up in the air. Housing is a difficult time, so access to food, and more people, as high as 14 million children in the United States, are having issues accessing proper and adequate nutrition levels. And the last we have is social context. So this is probably super important in the age of COVID-19. What kind of social integration do you have? Do you have a tight-knit family? Do you have a tight-knit group of friends to kind of help you in this difficult time? What support systems do you have? What is your level of community engagement? And some other variables are the level of discrimination and or stress you have to deal on a daily basis. So what are the data sources used and what are their limitations? So how are models, white papers, and studies compiled? It really depends on each specific study, but for a lot of my research and is in the medical claims, lab results, pharmacy claims. We analyze those on a daily basis. Program enrollments, are you enrolled in a Medicaid program? Are you enrolled in a Medicare program? Are you enrolled in a commercial product? Health assessments, census data is used by the public and private sector. Pretty comprehensive data set that is at that county level. A big topic recently because of COVID is electronic medical records, or EMR. There's a pretty severe latency in medical claims data in general. For a sophisticated, mature data set, I'd say there's about a 2 to 3 month lag. If it's a newer data set, more volatile, it could be experiencing a lag for up to 6 months. Electronic medical records are essentially the systems that the nurses and the doctors enter into every PCP visit, every ER visit. That stuff is tracked on a daily basis. So huge emphasis in the last 8 months to acquire daily COVID-19 inpatient analytics. There's also demographic data. member address, member zip code, member gender, member age, all very important variables. Some other studies could use behavioral data, psychographics, aggregated credit data, or some studies, and one we're going to get into, uses Google GPS data. So what are the various limitations that exist for data sets? A number of data sets in SDOH modeling are survey data. We have to take survey data with a grain of salt. The person filling out a survey data, say a member goes to visit their PCP and the PCP has them fill out a depression and anxiety survey. That data is at the subject's approval. So some people might not know the symptoms of anxiety. Some people might not accurately report their symptoms. So that's one thing we kind of have to keep in mind. It's also difficult to flag SDOH variables in some data sets. I think it's getting better as the industry progresses, and it's really been an emphasis over the last 5-10 years. We have this concept called ICD-10 codes. These are a classification of diseases. For instance, prior to 2020, there wasn't a COVID-19 ICD diagnosis code. So as new things emerge, we have to have the proper coding and the proper flagging in the data to do our reporting and analytics. And I think the biggest limitation of some of these studies is the difference between correlation and causation. So just because, variable A and variable B are, positively correlated or negatively correlated, doesn't mean variable A implies or is a causing variable B. So we'll kind of run into that in a couple of the studies we take a look at. So what research has been done? We're going to take a look at economic stability first. So there was a study done in September of 2020 called Racial, Economic, and Health Inequality and COVID-19 Infection in the United States. The methodology of this study was a correlation study between infection and mortality rates in various data sources. They compiled demographic and socioeconomic data from US Census data. They compiled mobility variables from publicly available Google GPS data. So I actually didn't know this. It's pretty interesting. Since COVID-19, Google has been tracking, for anyone who has a cell phone and has GPS on and has a Google phone, various rates of those people's cell phones being in different areas. So as a result of the pandemic, there's been a significant decrease in people going to bars and restaurants, significant decrease in people going to grocery stores. As a result, there's been a pretty significant increase in people going to parks, going outside, as well as staying home, which kind of corroborates what we would expect. But very interesting that is publicly available data. So they used that in the study. They also used infection and mortality data from the state government health websites. So they aggregated all this data for 369 counties in the US for the following states: Michigan, New York, New Jersey, Pennsylvania, California, Louisiana, and Massachusetts. So what were the results of this study? Before we jump into that, there's a pretty important distinction, that the difference between the infection rate, which is the probability of an infection with a population, the frequency of occurrence, versus the mortality rate, so the relative frequency of deaths in a specific population in a specified time frame. So what they found was quite interesting. The infection rate was positively correlated with diverse demographics and higher populations. Intuitively, this kind of makes sense. Places with more people might have a higher likelihood of having a higher infection rate. What's pretty interesting, though, is the same variables do not positively correlate with mortality rate. Populations with higher rates of disability and poverty were positively correlated with higher mortality rates. So let's just jump into some visuals of this. So on the screen, we have a graph that shows the correlation coefficient in the Y column, and the X column are the various variables that they aggregated from all the data sources. What's pretty interesting is if you take a look at some of the negatively correlated variables, they include poverty white, white male, poverty black. Again, this does not mean causation. That's an important call out that we kind of mentioned earlier, but find interesting study nonetheless. If we take a look on the positive side, the first few variables include black female, black male, park mobility. So when there was an increase in parks mobility, there was an increase in infection rates, total population, and median income. Let's jump to mortality rate next. So very similar concept. Y-axis is a correlation coefficient for the death rate, and X is the total, or X is the variables that they aggregated. What you'll see is that the variables change between infection and mortality rate, the ranking of them. So if you look on the far left, total population and median income were negatively correlated with the death rate. So the higher the population, the less likelihood of having a higher death rate in that county. Similarly, with median income, the higher the median income in a county, the less likelihood that that county would have a higher death rate. If we take a look at the far right, you'll see a number of poverty variables. First being poverty white, second being disability, third, poverty black, fourth, poverty, fifth, poverty female, poverty male. You could argue Medicaid is a function of poverty and disability, poverty Hispanic, poverty Asian. So you can kind of sense a theme that the variables that might correlate with the infection rate are not necessarily the variables that correlate with the mortality rate. There's definitely a theme in the variables that positively correlate to the mortality rate. So here's like a visual representation of what those bar graphs pretty much indicated. If you take a look on the upper left, that's the COVID rate, total population, so the infection rate. Counties that have a lighter green are less populated. Counties that have a darker green are more populated. So you can kind of see in the eastern part of the state over here, we have bigger rates of COVID-19 infections, whereas some of the more rural counties in the state would have lower infection rates. What's interesting is to compare this graph or map to the death rate population. Again, looking at total population, the lighter green being more rural counties, the darker green being more populated urban areas. And you can see that the urban areas actually have a lower death rate relative to some of these rural counties, which kind of corroborates the graph we had on the previous slide. If we also take a look at Pennsylvania, death rate, where the gradient displays the non-Hispanic white population. So more diverse demographics in the metro.
Looks like we may have lost her briefly.
More fortunate counties.
Okay, Shae.
Again,
Shae, I think we lost your audio for like the last minute.
Oh
no. So can you go back?
You guys hear me?
I can hear you now.
Yeah.
So can you go back to whatever you were saying like 60 seconds ago and start from there?
Yeah, absolutely. My apologies, you guys.
Well, I don't think it was your fault.
At the it could have been. Thanks, Gary. Yeah, so let's take a look at the COVID infection rate in the upper left-hand corner. You can see lighter green counties are less populated, darker green counties are more populated. So there's higher rates of infection with more people, which intuitively kind of makes sense. Compare that to the death rate, though. This is an interesting graph. You can see the darker regions that are more populated have a lower death rate relative to the counties that have a light green county, less people. This kind of, validates what we saw on the previous slide, the coefficient bar graph. If we take a look at the death rate, where the gradient is showing the non-Hispanic white population, you can see in more death rate, there's higher rates of COVID-19 deaths. And then similarly, we'll jump to median income in the bottom right-hand corner. Darker counties are poorer counties, and lighter blue counties are more fortunate. And you can kind of see median income negatively correlated to the death rate there. So that's a visual representation by county for Pennsylvania. So the study suggests evidence of economic and racial disparities in the population affected by COVID-19. Some of their potential causes they list are the distribution of essential workers, poverty and access to care. That's a big one in rural areas. And urban areas are better equipped to take an influx of patients. They have more doctors on hand, more resources, are better to equipped to handle an influx of patients. So that's sort of economic stability. Let's discuss educational attainment. So here's a flow chart from a 2015 CDC study that kind of outlines the relationship between educational attainment and health. So educational attainment impacts three items. It impacts the social environment, your work environment, and your health, knowledge, and literacy. If we take a look at what the social environment impacts, it impacts your sense of control, social standing, social support. Stress levels could be directly caused by this, family stability, health behaviors, all of which would impact an individual's health. If we take a look at the work-related items, working conditions, work-related resources, and income. So working conditions, exposure to hazards. Are you an employee that has to go in, like a doctor or a nurse, into a physical building with the exposure to various hazards? Or are you a data analyst that telecommutes from home? Work-related resources. A big one is, do you have health insurance? What are your sick leave? What other benefits does your work provide? And then obviously income, which could affect housing, neighborhood, nutrition, and stress, which again, all impacts your health. And then the last one is health, knowledge, literacy, and behaviors. So this impacts nutrition, drugs, alcohol, smoking, exercise, and other risk behaviors, and negotiating and navigating the healthcare system, which is not easy. Complex diagram shows that all of these variables impact an individual's health. What's interesting is then your health directly impacts your educational attainment, and as a result creates intergenerational health mobility. So if you're a healthy person, you're more likely to be able to go to class on a regular basis. If you're having chronic health issues because you're stressed, because you're exposed to hazards, it's going to be harder for you to reach higher levels of educational attainment. So it can become a vicious cycle. A 2014 study, Why Educational Attainment is Crucial to Improving Population Health, found via data derived from regression modeling that probability of death was negatively correlated to number of years in educational attainment. So men is in the purple category, women in the green category, but you can see as you increase your educational attainment, you have a lower likelihood of dying. So interesting study, again, all before COVID-19. So let's jump to today. Interesting study in June of 2020 from the McKinsey Company, a white paper called COVID-19 and Student Learning in the United States, the hurt that could last a lifetime. They had three different scenarios that they projected for. Scenario 1, return to in-class schooling in fall 2020. This is the viruses contained scenario. Second scenario, return in-class schooling January 2021. This scenario is called virus resurgence. And the third scenario, return to in-class schooling fall 2021. So when we look at scenario 2, which seems, maybe more likely than scenario 1 at this point, the studiers found an average months of learning lost compared to typical in-classroom learning. So in an average remote learning setting, they project a 3 to 4 month loss of learning. In a low quality remote learning, there is a 7 to 11 month loss of learning. And with no instruction, there's a potential for 12 to 14 months loss of learning. So what they did was project the various math performance scores for sixth graders, and they also quantified the educational loss by COVID-19 and how that could impact GDP. So you can see here in that first column, that's the learning loss that they project in the various 3 scenarios. And as a result of that lost learning, they project, as high as 1,100 in the thousands of additional high school dropouts. There are individuals who need to be in a physical building so that they have resources to guidance counselors, teachers, have social networks so that they can feel encouraged and finish high school. And we kind of outlined in the previous slide how the number of educational attainment years really can impact your health and a variety of other variables like your employment long term. So what they did was project this loss of learning could equate to, in a best case scenario, $80 billion lost in GDP by 2040. On the worst case scenario, could be up to 500 billion by 2040. And then that last column, they have annual earnings lost in the billions per year. All right, so that was education. Next, we're going to talk about social context. Before we do that, though, I want to give you guys some quick statistics and some definitions. First, there's a difference between social isolation and loneliness. Social isolation is defined as the objective state of having few social relationships or infrequent social contact with others, while loneliness is a subjective feeling of being isolated. Again, that would be gathered through survey data, so we have to take that with a grain of salt. In an effort to quantify the cost of loneliness in the US, the CDC found that for Americans aged 65 and older, social isolation cost the US government nearly $7 billion per year, pre-COVID. The CDC also found that major depressive disorder, suicide, and addiction cost the US $960 billion annually. Again, these are numbers pre-COVID. And studies have shown that loneliness is more dangerous than obesity and as damaging to health as smoking 15 cigarettes a day. Pretty astounding numbers there. So let's jump into this next case study. This was a case study done by the University of California, San Francisco. Loneliness in older persons, a predictor of functional decline and death. Methodology was a cohort study of 1,600 participants sourced from the Health Retirement Study, which was a national representation of seniors. The survey was conducted between 2002 and 2008, with the baseline being 2002 and following up every 2 years until 2008. Subjects were asked if they felt left out, felt isolated, or had a lack of companionship. Subjects were then categorized as not lonely if they responded hardly ever to all 3 of these questions. And lonely if they time or often to any of these questions.
So Shae, I think your internet hitched again. Your internet hitched again. I think we only lost like 25 seconds, so you don't need to go back a full minute. But if you could go back like 25 seconds.
Yeah, absolutely. My apologies, you guys. So in this study, they surveyed seniors in 2002 as the baseline, and they followed up every 2 years until 2008. They asked the subjects if they felt left out, isolated, or lacked companionship. And then over that time frame, they measured various variables in decline, including difficulty on activities of daily living, difficulty in upper extremity tasks, decline in mobility, and increased difficulty in stair climbing. Multivariate analysis adjusted for demographic variables, socioeconomic status, living situation, depression, and other medical conditions. What they found was that 43% of seniors feel lonely on a regular basis, and that there's a 45% increased risk of mortality in seniors who report feeling lonely. Again, pretty astounding numbers from before the pandemic. Fast forward to today. During the pandemic, here is a survey from the Kaiser Family Foundation. It measures weekly data from May, June, July of 2020. In the left-hand box is depression as high as 25% and one or the other as high as 35%. And you can see as the duration of the pandemic has increased, all levels of anxiety, depression, and or both have increased as well, escalating in June and July. So prior to the pandemic, there were two epidemics happening in our country. One being the loneliness epidemic, which we just discussed, cost the US billions of dollars a year. The other epidemic was the opioid epidemic, or the substance abuse epidemic. When two epidemics collide with a pandemic, this is the results you can see. During late June, 40% of US adults reported struggling with mental health or substance abuse. As high as 31% reported anxiety and depression. About 13% said they started or increased their substance use. 26% said they had trauma or stressor-related disorder symptoms like PTSD. And unfortunately, as high as of 11% seriously committed or seriously considered suicide. So these are pretty staggering numbers and kind of illustrate when a pandemic that requires us to socially isolate collides with two epidemics. All right, so that kind of concludes our case study portion of the lecture. We're now going to move on to what is the future of healthcare data analytics in the healthcare industry, especially in the time of COVID-19. What is big data? I'm sure many of you have heard this term thrown around quite a bit, but let's define that. Big data is so voluminous and complex that it can't be analyzed with your usual data processing applications. Big data is multi-structured. In healthcare, different organizations use different structures, types, formats, and much of the data has no structure at all. And that is really kind of my area of specialty, is how we ingest all these different file formats, how do we map different code sets so that we have an apples to apples comparison across, payers from across the nation. And then big data is multi-source. We kind of touched on this earlier in the lecture, all the various sources that could feed an SDOH model. Healthcare data resides with payers and providers in the form of claims data, clinical data, and status data. What is actionable data? Actionable data is accurate, insightful information that can provide an organization. You guys lose me? Let me start again. I think I lost internet.
After you said actionable data.
Thank you. Actionable data is accurate, insightful information that can provide an organization with insights that improve patient care, reduce risk, and strengthen the bottom line. Actionable data is standardized. Standardized data is cleansed, has common terminology, allowing for apples to apples analysis. So like I mentioned on the last slide, this is really my area of expertise. How do we standardize data in a centralized format that's easy for users to consume so that they can benchmark various providers in a similar zip code, and how effective they are at providing care. Actionable data is predictive. Predictive data illuminates patterns from the past that can foretell trends in the future. Actionable data is preventative. Preventative data is the foundation of evidence-based care, which OptumCare is nationally recognized for. With it, providers are able to find out which treatments are best and most cost-effective. Actionable data is timely. Timely data does not come from claims like we discussed earlier. It can have a 3 to 6 month lag. It comes from EMR and other provider information systems that show patients are being treated and where they're being moved. Did a COVID-19 patient come in? Did they get admitted to the ER? These are the kind of metrics that various agencies would like to track on a daily basis. Actionable data is comprehensive. Comprehensive healthcare data does not just include claims, but multi-source clinical data, socio-demographic data, and admit and discharge data, which allows for a more detailed picture of patient and health activity. So with all the big data implications, there's so much data and almost too little time to analyze it. That's why various study, research companies have been leaning on AI and machine learning to really understand and comprehend and digest this data faster than ever before. Translating data into effective policy and business decisions. There's a number of things going on currently or going on historically. Local governments are investing in Medicaid and Medicare programs. Some, you could argue that Medicaid recipients and Medicare recipients are maybe our most vulnerable people in society, especially when it relates to COVID-19. The private sector is investing millions of dollars in providing homes for homeless individuals. For some companies, it's more stable and less risky to provide rent income of $500 a month versus being on the hook for a $100,000 ER bill that could have been easily avoided if an individual had, say, more, stability in their life. As a result of COVID-19, and even prior to that, there's been an emphasis on expanding telehealth services to combat health disparities. In that economic stability study, we kind of saw that rural areas had a higher death rate, potentially related to having less access to care. Granted, not every service can be handled on a telehealth visit, but utilizing that to kind of reach out to people more often, more frequently, create that PCP connection with various members. Some agencies and payers are offering subsidized COVID-19 testing. The thought process there is we wouldn't want financial income to limit your ability to get tested and probably get latency in their COVID-19 results. There's also been an increased emphasis on investing in mental health and substance abuse services. There's also been an emphasis on securing financial resources for our most at-risk members of society, as well as just stimulus talks in Washington happening now. Big picture. What does this all mean to maybe people on the call? There's a number of public and private entities that are in need of analytical talent. Have it be actuaries, data scientists, business analysts, developers, or economic consultants like myself. Maybe on a more personal level, I read all of those statistics and was kind of baffled at how high some of the depression rates and substance abuse rates are. So really, want to emphasize taking care of yourself and those in your social community and broader community, following CDC guidelines. There's been a real effort, thinking about the educational attainment pillar of SDOH. In Tennessee, the local education government has recruited a number of college students to volunteer their time to help out students K through 12 who are in need of additional tutoring resources, um, taking advantage of free mental health resources, and then using social media and technology to stay connected with family and friends. So that concludes my lecture. I have a number of sources here on the various slides, but I can open the floor to questions.
So Shae, I have a couple questions if the audience won't. So the first question is just logistical. You will share with me the slides, correct? And then we can make those available. Okay.
Yep. Definitely encourage you guys to check out the various sources.
And well, I'm going to jump just straight to the audience because there's a question from the participants. It says, when you standardize data for actual modeling, how much do you do some type data transformation? What types of transformations? For example, do you average or select medians or certain data streams to reduce the set, elect certain ones for causal data versus just correlated, eliminated outliers, etc.?
That's a super good question. And that's not my area of expertise, but what I can probably speak to is a variety of different variables coming in from different payers. So within a given entity that we have to, price claims for, there could be up to 500 different data formats. And what is the best way to streamline that and maps certain values to a valid code set, making sure we have valid ICD diagnosis codes, valid bill type and revenue codes and procedure codes. Good question. Yeah, that I'd have to ask some of my actuarial friends on the median and certain data streams. Good question.
Other questions? I'll go back to the question that I was going to ask you. I got one here. Well, let me ask my question. I'll come back to this next question too. So my question to you was, from your perspective, or if someone were to say to you, working as someone whose background as an actuary and also economics, and in the role that you're in now, what would you say are your biggest challenges on a day in and day out basis? And what are the things that you learned as an undergraduate that was most useful for you? And what did you wish that you had learned as an undergraduate that maybe you didn't?
Yeah, those are really good questions, Gary. I'm going to take the first one, which I believe was skills that I use on a daily basis. And not to plug Math 4067W, but the skills in that class, which were executive summaries, writing emails, effectively communicating different trends, the Excel knowledge that you learned in that class was quite helpful. And how do you create a pivot table? Those are the kind of things that we do on a daily basis. So I definitely would plug that class, or really any class that emphasizes Excel, SQL, Access, any of those database tools that kind of lay the foundation. You might not use that in your day-to-day job, but SQL, Access, and Excel really are kind of the foundation of many languages. And also just I think that the business aspect as well. There's a lot of insurance classes that have historically been required. Just kind of giving the context of what are deductibles, what are co-payments, those kind of things, and really just all of the math classes gave a pretty heavy dose of critical thinking. One thing I think is a challenge for me personally, that was kind of a transition period coming out of college, was In college, when you had a math problem, you always had like an objective right answer. Um, in the real world, whether that be at a company like Optum, an organization like the CDC, any of the various data sources and studies we kind of mentioned, it's not always clear what the right answer is. In all these models, they're making assumptions. You could probably write a 10-page dissertation on each of those assumptions and how valid they are. So really trying to, make assumptions and have justifications for those assumptions when you're doing modeling. Not as clear cut as, say, a statistic problem, an integral of a function. There's a concrete right answer. So having that subjectivity involved with something that is in your mind so objective, which is data and math. So taking everything with a grain of salt. Good question.
So a follow-up question from a student in our Master's in Financial Mathematics program. And I'm going to augment the question. I'm going to read the question to you, but then I'm going to augment it a little bit as well. The question is, what would you recommend a first-year Master's in Financial Mathematics student do to enter a field like yours? And I'm going to broaden it a little bit and say, maybe that question could be coming from anybody who's getting, say, a master's or PhD in a STEM field.
That's a really good question. I think as someone, as we're hiring people in, Optum, just other companies I've been a part of, an emphasis on technical skills has really been kind of a precursor to someone we would potentially hire. Even it doesn't necessarily need to be in a class. It doesn't even need to necessarily be in, an official capacity. We had someone apply to a job once who was super into baseball and used Excel to do baseball modeling and statistics and probabilities and projecting all that. It wasn't necessarily related to healthcare, but it kind of showed that passion, that ingenuity, and kind of, sold to us that, hey, this is someone that I think we want to bring on board. So sort of that, how do you use your technical skills to, show that you're a passionate person about, any of the topics we discussed. Good question.
That's a great response too. I'll say that somebody who hired a lot of people over the years when I was an actuary, that it was always important to me that somebody had passion for the technical stuff, and so that was one of the ways you can differentiate yourself is to show that I really have passion for this. And I've done stuff on my own. I've gone and I've applied it to baseball, which may sound, almost, maybe it's frivolous, but you know what? It shows they have passion for using numbers and applying it to something that they actually care about.
Absolutely. Awesome. Any other questions on this cold Friday evening?
I'll ask another question if there's, first of all, I want to encourage anybody from the audience to ask another question.
Absolutely.
I don't want to ask all the questions. So my question is that, oh, here we got one. We got one for you. The current graphs and models behind them that you showed, do you expect them to change in the coming year as more data comes in? The current graphs, not the graphs. So I read that literally because I didn't know what was meant, but
the current graphs.
The graphs and models, not the grass and models. Okay.
Okay, I'm following. No, that's a really, really good question. And that's probably a very, important call out to make is, we're still in the infancy stages of this pandemic. The 1918 flu pandemic took 3 years to recover from. So if that's anything like what we're in now, I would expect as the time horizon expands, we'll get more data. Like I said, there's some data sets that have pretty extreme latency, so we don't even really know what we don't know. It'll be really interesting, and I think as a result of COVID-19, I would just expect in general that healthcare data analytics the demand for that to increase, because we just don't fully realize the the magnitude of how serious this pandemic is, not just in accounts of mortality rates or infection rates, but long-term social impacts to I've heard crazy stories of like kindergartners trying to learn on telecommute. That's crazy. They don't really have an alternative, but really the long-term impact of this is going to be told and talked about for generations, just based on past historical events.
That might actually provide a nice segue to the next question I have, which is, how does one maintain hope when studying such grim material?
That's a good question. I really think what I try to do is have the mentality, like, how can we be part of the solution? What insights can we gain from the data? I allude actuarial science sort of like, weather. It's not perfect. It's not always accurate. There are, issues, but if you're going on vacation in Hawaii, there's no way you're not going to check the data, check the weather. So it's the best information we have today, and really just trying to emphasize, especially at OptumCare, being part of the solution. How do we get data in people's hands faster? How do we make sure the data is more reliable? And really what we've been doing is working around the clock to get information in providers' hands so that they can better treat their patients, not just COVID, but just in general. I mean, but some of the statistics I did show are quite grim. So I think it's just banding together as a community, whether that be the U of M community, the actuarial community, and just general population. Got to band together. Quite an unprecedented time.
Other questions? If not, I want to really thank you, Shae. That was a terrific presentation. A lot of very good information, and I think the real nerds in the audience will look forward to getting your deck so they can go click on the links and maybe look at
Awesome.
some of those papers a little deeper. But definitely a timely topic. Definitely something that is germane for everything that's happening right now.
Compiling this and really awesome. Thank you guys so much. Really appreciate you guys taking some time on a Friday night to geek out with me.
So give our speaker a hand.
Thank you. Thank you guys
everyone.
so much. Thank you. Have a nice evening.
Thank you.
Say.